This is a review article by Shenje et al. Published in 2020 about digestive tract reconstruction option after laparoscopic gastrectomy or gastric cancer, that is after distal gastrectomy. So in this study, they found that there were mainly four types of reconstruction methods commonly reported all over the world. Figure A was Billroth reconstruction, that in which we do distal gastrectomy followed by gastro-jejunostomy. Second is Billroth 2 with Brown modification, in which we bring the loop of jejunum and do gastro-jejunostomy, and in between the loop we add Jejuno-jejunostomy to prevent the reflux of the bile. Third was Roux-en-Y, and fourth was uncut Roux-en-Y, in which we fire uncut stapler distal to the gastrostomy and add Brown's anastomosis, that is Jejuno-jejunostomy, to prevent the reflux of the contents. Namaskar viewers. In today's video tutorial, we have discussed in detail about different reconstruction methods after gastrectomy. The main reconstruction technique discussed are Roux-en-Y, double tract reconstruction, esophago-gastrostomy, and loop gastrostomy. These reconstruction techniques are required after total, distal, and proximal gastrectomy. We have reviewed the relevant literature regarding these techniques and which technique is to be followed in the different circumstances. We have also discussed about double tract reconstruction in lap proximal gastrectomy, in which we have demonstrated the technique in a live video, and also in the video on recent advances on CS stomach. I will give the link to those videos in description and in this video also. So mainly the reconstruction method after gastrectomy are: in the fig A, it is showing double tract reconstruction after proximal gastrectomy, that we will bring a loop of jejunum in a Roux-en-Y manner to esophago-gastrostomy, gastro-jejunostomy, and jejuno-jejunostomy. Another option after distal gastrectomy, that is fig B, will be double tract reconstruction in the form of gastro-jejunostomy, duodenojejunistomy, and jejuno-jejunostomy. And in the fig C, that is after total gastrectomy, the double tract reconstruction is possible in the form of esophago-jejunostomy, duodenojejunistomy, and jejuno-jejunostomy. Briefly, the double tract reconstruction method is preferred because it enables the endoscopic access to the ampulla, which is a big advantage because in future, if there is any need for endoscopic access to the ampulla or the CBD, for example, in case of CBD stone or periampullary malignancy, then this route is easily available. Another advantage is, in case of proximal gastrectomy, the remnant stomach, that is distal stomach, is available for the food, and patient can have one-time meal. Viewers, please don't forget to like this video and subscribe to our channel and hit the bell icon for future important updates. So other options after gastrectomy are in the fig D, that is after proximal gastrectomy, we can do esophago-gastrostomy. We will pull the remnant stomach to the esophagus and do the esophago-gastrostomy. Or it can be in the form of Roux-en-Y, that will bring the Roux loop and we do gastro-jejunostomy and jejunostomy. Or Roux-en-Y after total gastrectomy, that is esophago-gastrostomy and jejunostomy. In this part, in the Roux-en-Y, the difference between DTR and Roux-en-Y is that we will not do the anastomosis with the duodenum or the remnant stomach. We will review the benefits of these techniques in the subsequent part of the video, so stay tuned. So, important question often asked is that why not esophago-gastrostomy after laparoscopic or open proximal gastrectomy? That, as I said, we will bring the remnant stomach and anastomose with the esophagus, that will do esophago-gastrostomy, and we will avoid extra suture lines. In a study by Abrutani et al., the incidence of both reflux, esophagitis, and anastomotic stricture was studied. In this study, there were 19 patients in the double tract reconstruction and 22 patients in the esophago-gastrostomy group. The reflex symptoms were higher, that is 10.5% versus 54.5%, and it was statistically significant. And also, PPI use was higher in case of esophago-gastrostomy, and it is easier to understand that when we bring the stomach with the gastrin-producing antrum in situ, there's a production of acid, and there is no valve which will prevent the reflux of the acid into the esophagus, which is there in the normal anatomy, that esophago-gastric junction will prevent the reflux of the acid into the esophagus. So there are higher reflux symptoms and a higher anastomotic stricture subsequent to this reflux of acid. So they also reported that anastomotic stricture were higher, 0 versus 27%, in the esophago-gastrostomy group. So from this study, they recommended that after proximal gastrectomy, double tract reconstruction is preferred method as compared to the esophago-gastrostomy, especially in the young patient who have long life to live, and there are higher chance of reflux, Barrett's, and anastomotic stricture. In the same study, this is the by Aburtani et al., which was published in 2017. This is the schematic illustration of double tract reconstruction and fluoroscopy using diitrojet meglumine and diitrojet sodium as the contrast medium, and it showed that the medium passing through the remnant stomach and the rest directly to the genome. So when the patient swallowed the contrast media, it went into the remnant stomach, which is visible in this X-ray film, and into genome. So both the distal stomach was available for the food, and it was going into the genome also. So patient can have one-time meal. That was the advantage of double tract reconstruction, and also there is a easier access to the ampulla, as I said, endoscopically. This is another important study by Rosa et al., which is published in Gastric Cancer in 2018, and in which they studied total versus proximal gastrectomy for adenocarcinoma upper third of stomach, a propensity score matched analysis of a multi-center Western experience on behalf of the Italian research group for gastric cancer. So for proximal one-third CA stomach, they did total gastrectomy with proximal gastrectomy, and in the total gastrectomy group they did Roux-en-Y, and in the proximal gastrectomy group they did esophago-gastrostomy, and they reported, as highlighted, that the anastomotic leak was higher in the proximal gastrectomy group, though it was not statistically significant, but the reflex esophagitis and anastomotic stricture both were statistically significant in the proximal gastrectomy group, followed by esophago-gastrostomy. This is another study, a comparative study of double tract reconstruction and Roux-en-Y gastrectomy for gastric cancer by Jejuno et al., published in 2019. In this study, 595 patients were studied. It is a review article which included 595 patients and total 8 study. And in this meta-analysis, there are 262 double tract reconstruction and 333 Roux-en-Y reconstruction. From this study, from this meta-analysis, they reported that there was no significant difference in the operative time, and out of 8 studies, 2 studies reported time to first platters, which showed no significant difference after meta-analysis, and there was significant shorter time to oral trach in double tract reconstruction than Roux-en-Y. The length of hospital stay post-operative complications was similar in the both group, and albumin level, there was no significant difference at 6 and 12 months after the surgery. This is an important article, and I request the viewers to go through this meta-analysis. The forest plot comparing body weight change at 2 years after surgery showed that the decrease of body weight was significantly more in the Roux-en-Y group than the double tract reconstruction at 2 years after surgery. So the authors concluded that DTR is better as compared to Roux-en-Y. Another important question which is there or often asked by the trainees is how much should be the length of the interpose segment between the esophagus and the stomach. The previously interposed jejunum in the DTR was more than or roughly equal to 30 centimeter. Long jejunal interposition segment between esophagus and stomach created difficulty for the endoscope during post-op follow-up. Longitudinal segment more than 20 centimeter did not reduce the reflex incidence of acid into the esophagus. The interposed genome was 10 centimeter in DTR group in the study by Ahen et al. And 15 centimeter in the group by Nomura et al. So 10 to 15 centimeter interposed genome segment may be appropriate length to prevent the reflex esophagitis symptoms. As given in this picture, the esophagus to ruminant stomach, this segment should be around approximately 10 to 15 centimeter, and from stomach to the jejuno-jejunostomy side, it should be around 20 to 25 centimeter. This is another important study by Lee et al. Published in World Journal of Surgical Oncology in 2019. In the study, about comparison of three digestive tract reconstruction for the treatment of severe type 2 and type 3 adenocarcinoma by esophago-gastric junction. This was a randomized prospective randomized control study. In this study, they compare single tract reconstruction in which they did the Roux limb was brought up and they did esophago-jejunostomy and gastrostomy, and uncut stapler was fired distal to the gastrostomy side, that is there in the first figure as single track reconstruction. And double track reconstruction was same as we discussed, that was esophago-jejunostomy, gastrostomy, and jejuno-jejunostomy. They study the difference in body weight, hemogram, total serum protein, serum albumin, and blood vitamin B12 between three groups at 3, 6, 12, and 18 months after the surgery. They also study the basic score, which is used to evaluate the gastroesophageal reflux symptom. And basic grade 1 is when patient is asymptomatic. Basic grade 2 is when patient has occasional symptom. And basic grade 3 is patient has apparent symptom, but these are tolerable. And basic grade 4 is apparent and intolerable symptoms. The authors reported that the basic score grade 4 was more in total gastrectomy followed by Roux-en-Y reconstruction method, and it was statistically significant. And they also found that single track reconstruction, that is when we fire uncut stapler distal to the gastrostomy side, was better. This is a review article by Shenje et al. Published in 2020 about digestive tract reconstruction option after laparoscopic gastrectomy or gastric cancer, that is after distal gastrectomy. So in this study, they found that there were mainly 4 types of reconstruction methods commonly reported all over the world. Figure A was Billroth reconstruction, that in which we do distal gastrectomy followed by gastroduodenostomy. Second is Billroth 2 with Brown modification, in which we bring the loop of jejunum and do gastrojejunostomy, and in between the loop we add jejuno-jejunostomy to prevent the reflux of the bile. Third was Roux-en-Y, and fourth was uncut Roux-en-Y, in which we fire uncut stapler distal to the gastrojejunostomy and add Brown's anastomosis, that is jejuno-jejunostomy, to prevent the reflux of the contents. The authors reported that this delta-shaped anastomosis is the most common intracorporeal Billroth 1 anastomosis after laparoscopic distal gastrectomy, and it was first reported by Kanaya et al. Published in 2002 in Journal of American College of Surgeons. In this technique, authors reported that distal gastrectomy is performed and the duodenal valve is transected in ventro-dorsal direction. That is, we fired a stapler vertically and following which endoscopic linear stapler is used to create the anastomosis, and closure of the common stab incision done with the help of another endo-GI stapler. Thanks for watching, viewers. I hope we were able to add some new insight to your knowledge. Channel subscription is free for lifetime. Knowledge is invaluable. Please like, subscribe, and share the content. Thanks for watching again. Happy learning.